Greetings everyone, I am Ashwini KULKARNI and I present to you an interesting case with a terrible twist. Our patient was a 21-year-old male from Ramnagudam, West Godavari, Andhra Pradesh, who came with complaint of left eye blurring of vision for distance and near since 1 year. He had no history of trauma, any systemic illness, or significant past history. His general and systemic examination were normal. His BCVA in right eye was 20/20 for distance and 6/6 for near. Left eye BCVA was 22/50 for distance and 6/36 for near. External examination was normal. His right eye anterior segment and fundus were unremarkable. On left eye examination, anterior subcapsular cataract was seen. On fundoscopy, rhegmatogenous retinal detachment involving macula was noted with break at 6 o'clock and subretinal bands. With this, provisional diagnosis of right eye emetropia and left eye subtotal macula of rhegmatogenous retinal detachment with anterior subcapsular cataract was made. For this, patient underwent vitreoretinal surgery. However, there was recurrence of retinal detachment under oil, for which patient underwent PFCL silicone oil sandwich technique. 6 weeks post-op, patient was stable, BCVA was 2600, retina was attached, but there was extensive emulsification of silicone oil. So patient was taken up for left eye PFCL silicone oil removal. However, patient was lost to follow-up and he presented to us 4 months later with left eye BCVA of hand movements, full chamber hyphema and raised IOP. B-scan showed dispersed VH, suprachoroidal oil, and retinal folds. Patient was taken up for AC wash, vitreous lavage, and fluid gas exchange. But as soon as AC wash was started, there was a twist. Numerous iris cysts and neovascularization of iris were seen. Here we can have a clearer view of the iris cysts. Old and fresh VH was cleared. Here we can see the fresh VH is being cleared. A retinochoroidal opening was made to drain the suprachoroidal oil, but this alone was not enough. Suprachoroidal oil was expressed by massaging the sclera. Here we can see this maneuver being performed and the silicone oil is being expressed out, and the irises were extending up to anterior retina. The irises were gently dissected with a Sinskey hook and removed out with intraocular forceps for histopathological examination, and the rest were cleared off with cutter. On H&E staining, tumor cells were seen as infiltrating cords and focally forming rosette or acini embedded in a myxoid background. Nuclei of these cells showed minimal pleomorphism. The myxoid background is highlighted on Alcian blue stain, indicating the hyaluronidase-sensitive mucopolysaccharide, also termed as neoplastic vitreous. As histopathological features were suggestive of medulloepithelioma, uveum was suggested, which was showing ciliary body thickening with irregular margins and few small cystic spaces with no definitive mass. Simultaneously, immunohistochemistry was performed. In view of mild pleomorphism, absence of mitosis, and low Ki67 index, diagnosis of benign medulloepithelioma was made. So with this terrible twist, let us discuss briefly about medulloepithelioma before going back to the case. Medulloepithelioma is an embryonal neuroectodermal tumor arising from non-pigmented ciliary epithelium, usually seen in children between 2 to 5 years of age, with 90% presenting in first decade. There are very few reports of adult medulloepithelioma. Fuchs et al. Hypothesized that neoplastic transformation of hyperplastic ciliary epithelium in inflamed or traumatized eyes could be the reason for medulloepithelioma in adults. It can present with blurring of vision, painful red eye, leukocoria, strabismus, or could be asymptomatic and detected incidentally. It can present as a ciliary body mass which appears fleshy, whitish pink, vascularized, with cysts either on the surface or free floating in AC or vitreous. Sometimes we can see chalky white deposits in teratoid type. It can present as secondary glaucoma, most common being neovascular glaucoma, So whenever we see unilateral neovascular glaucoma in a child with normal posterior fundus, we should always suspect occult ciliary body meduloepithelioma. It can present with lens changes such as segmental cataract, lens subluxation, or a lens notch. In case of Willems coloboma, in absence of uveal coloboma, always look for a ciliary body mass. Other features which can be seen are retrolental cyclitic membrane, hyphema, retinal detachment, PHPV, or extraocular extension. UBM is the investigation of choice for ciliary body meduloepithelioma, in which we can see medium to high reflective ciliary body mass with characteristic intratumoral cysts. Shields et al. Noted in their study that 60% of the cases had intratumoral cysts, and calcification or areas of cartilage within the lesion appear as high reflective dots. Considering the UBM showing ciliary body cysts and histopathological features suggestive of meduloepithelioma, a final clinico-pathological diagnosis of left eye ciliary body meduloepithelioma was made. Management options for this condition are local resection, that is partial lamellar sclerouvectomy, which can be done for small tumors less than 3 to 4 clock hours, but there are high chances of recurrence. Other conservative management options are cryotherapy, plaque brachytherapy, systemic chemotherapy. However, enucleation is the preferred method of treatment, especially in large tumors, friable appearance, retrolental membrane, and free-floating cysts. Meduloepithelioma are slow-growing, locally invasive tumors with extrascleral spread and metastasis. However, extrascleral extension cases can have metastasis. KULKARNI et al. In their 41-case review, 7% had extrascleral extension, and all these 7% developed metastasis, with 33% of tumor-related deaths in cases with metastasis. Hence, extrascleral extension is the key prognostic factor for tumor-related death. Coming back to our case, patient had HP diagnosis of meduloepithelioma and underwent multiple intraocular surgeries with high risk of extrascleral extension. Hence, patient was planned for and underwent left eye enucleation with implant. After histopathological evaluation of enucleated specimen, a final diagnosis of non-teratoid malignant meduloepithelioma was made. On latest follow-up, patient was doing well with left eye having healthy socket, central implant, deep fornicis and a well-fitting COP. But CT was advised for systemic evaluation, which was normal. Our take clinic message is that presence of ciliary body mass with cysts, neovascular glaucoma and normal fundus with a segmental cataract, one must always rule out meduloepithelioma. UBM is the investigation of choice which shows solid mass with intratumoral cysts, and atypical presentations are seen in meduloepithelioma. Therefore, high index of suspicion and histopathological examination helps in early diagnosis. Thank you for your patient listening.